Hello, I'm Bobby Jean Schweitzer. I'm a professor of anesthesiology and critical care and medicine at the University of Chicago, and I'm going to be covering anesthesia for electroconvulsive or ECT therapy, ophthalmologic, and laparoscopic surgeries. I have no disclosures. This lecture module covers exactly what I just said it was going to cover in the title, and we're going to start with ECT. So, most of you probably know that ECT is most commonly used for depression, bipolar disorders, and schizophrenia, but most commonly depression. It's basically a generalized induced epileptic seizure by electrical stimulation of the brain. The most important aspect is the duration of the seizure for its therapeutic effect. So patients generally come in for ECT every other day for their active treatment period, and then that typically gets they're either done, or then they may come back for what's called maintenance therapy, which may be once a week, once a month, or even less frequently. So often there's accumulated information that you can gather on these patients as to how they've done with their previous ECT and alter your technique. But an important point to remember is the duration of the seizure correlates with the therapeutic effect. So with ECT, this electrical stimulation, which is applied to the brain, induces an initial tonic phase, which is associated with parasympathetic stimulation. There's usually brief bradycardia and even sometimes asystole. This is followed by a clonic phase. So the tonic phase is when they just get stiff, and the clonic phase is when they start to shake or jerk. And the clonic phase is associated with sympathetic activation and stimulation, which results in hypertension, tachycardia, and arrhythmias. So you basically need to induce general anesthesia, but it's a very relatively brief general anesthetic, and generally it does not require airway manipulation in the form of an endotracheal tube or a supraglottic airway. So you generally pre-oxygenate the patient. Often they will have the patient hyperventilate, which can help induce the seizure. Propofol is the most commonly used hypnotic agent. You try to use sort of low doses because propofol can decrease the activation of the seizure. For patients who have a contraindication to propofol, and in the past we frequently used methotrexate. Methotrexate is associated with nausea and vomiting. Propofol is not, and methotrexate is the currently the only, I think, other drug that is used that decreases the incidence of seizures, but still, if used in very low doses, does not impact the activation of a seizure enough. Other barbiturates that have been used in the past are longer acting and have more profound seizure depression effects, but I don't believe are available in the United States anyway any longer. So anyway, then one also wants to induce not only unconsciousness, so the patient is unaware that they're having a seizure and being stimulated, but also limit the amount of muscle contractions and jerking to limit the injury. In fact, once anesthesia started to be provided to patients having ECT, the outcomes improved significantly from a decrease in morbid conditions such as death, ischemia, arrhythmias, and broken bones. So typically one uses a short-acting muscle relaxant. Succinylcholine is the most commonly used. You don't usually need full intubating doses. You want it to wear off relatively quickly because the patient now has a short post-ictal state after the seizure, and then they want to be awake and up and ready to go home. If for some reason succinylcholine is contraindicated, then rocuronium in small doses can be used, though typically you may need to mask ventilate the patient after the seizure because it will last longer than the patient can tolerate being apneic. A bite block is a very, very important component of this to avoid injury to teeth, tongue, or lips. There are commercially available bite blocks, or you can roll up 4x4s and use those instead. There's significant hemodynamic perturbations with heart rate and blood pressure that occur, but they come on quickly, they end quickly, and generally they are not associated with significant morbidity and mortality. For selected patients, though, you may want to blunt the sympathetic nervous system in patients at risk for significant severe hypertension, those with aneurysms, those with a significant risk of arrhythmias, those with ischemic heart disease. You may want to limit the rise in blood pressure and heart rate. So it's best to, rather than treat the conditions once they occur, because they are so short-lived, is to prophylactically give medications to prevent the increase. So some of the most commonly used medications are beta blockers. Esmolol and labetalol are particularly good. Labetalol has more effects on the blood pressure than it does on the heart rate. Esmolol typically has more effect on the heart rate than it does on the blood pressure. Now, when you do give beta blockers, if you give them too far ahead of the stimulus or in too large amounts, that can exacerbate the bradycardia or the asystole, but generally it does not. An alternative is using remifentanil, alfentanil pre-seizure to also blunt the sympathetic output flow. So let's do a question. A 44-year-old patient with bipolar disorder is scheduled for ECT. He's extremely anxious and preoperative blood pressure is 166/98. Which drug is contraindicated? Which drug should you not be using? A, esmolol, B, labetalol, C, fentanyl, D, propofol, or E, midazolam? Which drug is contraindicated pre-ECT? So midazolam, which is, usually our sort of go-to drug, right, in the preoperative period, particularly to treat anxiety. The reason this drug is contraindicated is because it will raise the seizure threshold. It will make it more difficult to induce a seizure, and it will shorten the duration of the seizure, all which are correlated with the therapy. And remember, the patient's coming in to have this to treat their depression. So benzodiazepines, as mentioned, raise seizure threshold. All of them raise it. There is no, I don't believe, benzodiazepine that's considered more favorable than another. Midazolam would be considered more favorable just because of its short duration of action, but not because of the intensity of its change on the seizure threshold. Propofol may shorten the duration of the seizure as well. The larger doses of the propofol you use, the more likely that is. Remember, at least a 20-second seizure is optimal for therapeutic effect. Hypercarbia increases the seizure threshold or makes it harder to induce a seizure. So if you induce anesthesia and they're not ready to give the stimulus and the patient's apneic and their CO2 rises, then it'll be harder for them to induce a seizure. So a couple of things is sometimes when patients are difficult to induce seizures, they'll ask you to have the patient hyperventilate before. You can hyperventilate them with a mask. You also want to just make sure that the psychiatrist is ready to apply the stimulus and induce the seizure before you induce anesthesia. It's usually patients can hyperventilate better themselves than we can hyperventilate for them with a mask. Etomidate can be used as well. It has actually been shown to not decrease or not to change the seizure threshold. But the reason etomidate is not typically used, even though it has a favorable effect on the seizure itself, is because repeated doses can cause adrenal suppression. In fact, even a single dose generally causes adrenal suppression, but not clinically significant. Repeated doses, and because these patients come back every other day, often for weeks at a time, that would be a concern. And the other thing is that etomidate causes nausea and vomiting, and so that would be something that would not be very desirable. Another question, a 69-year-old is scheduled for ECT for severe depression. He has a history of hypertension and had a cardiac stent 5 years ago. Which method is best to avoid a risk of ischemia? A, administer twice the usual dose of propofol. B, administer 0.5 milligram per kilogram of esmolol immediately after the electrical stimulation for seizure induction. C, administer 0.5 milligram per kilogram of esmolol 30 to 60 seconds before the electrical stimulation for seizure induction. D, administer 0.5 milligram per kilogram of propofol 10 seconds after the start of the seizure to limit the seizure duration. E, decline to provide anesthesia for the ECT. E would be effective, but maybe not best for the patient. So vote, and that is the correct answer. So remember, the key is to provide this right before the stimulus to prevent it rather than treat it, because the tachycardia is generally so short-lived that it's not, by the time you treat it, it's going to be going away on its own. The reason you don't want to administer twice the dose of propofol is because that would make it harder to induce a seizure, and it would make the seizure shorter, and that would interfere with the therapy that you're doing. Again, you don't want to do anything that limits the duration of the seizure. So let's talk about ophthalmologic anesthesia. So there's some overarching goals that are important. One is obviously analgesia, or having pain-free surgery for the patient. Another is akinesia, or globe immobility, or the eye not moving around. It's not that dissimilar to general anesthesia, when one of the key goals is having an immobile patient, or a patient who doesn't move. But this is very important because the eye can move in so many different directions, and the patient may just be voluntarily moving the eye out of fear, anxiety, or something. And so having them, hold their eye still is very important. Avoidance of the oculocardiac reflex. Awareness of drug interactions, because some ophthalmologic drugs can have significant interactions with drugs that you're going to be using, and that the patient is not going to be coughing, straining, or having post-op nausea or vomiting, either coughing or straining during the procedure itself or afterwards, because that can increase intraocular pressure and cause a problem. Control of intraocular pressure is an issue, and of course then the overall safety. So let's talk about intraocular pressure, and they do like to ask questions on the boards about intraocular pressure. It's a balance between the aqueous humor production and the drainage, because it's the presence of the fluid in the globe. More fluid, higher pressure. Lower fluid, lower pressure. So it drains through the eye into the superior vena cava and then down into the right heart. So obviously any level of obstruction anywhere from the heart all the way back up to the eye will increase the intraocular pressure, because it will inhibit drainage of fluid. So normal intraocular pressure is typically 10 to 22 millimeters of mercury, and one can see sustained increases during anesthesia. Those can occur from a variety of reasons. If you do have sustained increase in intraocular pressure, that can result in acute glaucoma, retinal ischemia, hemorrhage, or permanent visual loss. So it's something that we want to avoid. So inhaled and most IV anesthetics cause dose-related decreases in intraocular pressure. So again, the way I remember this is, most anesthetic agents are depressive agents. They depress respiration, they depress cardiac output, they depress your blood pressure, and they also depress intraocular pressure. However, ketamine is the exception to that. It's controversial whether ketamine actually increases intraocular pressure. It probably does not increase it. It just doesn't decrease intraocular pressure. But the key problem with ketamine for eye surgery is ketamine can cause a rotatory nystagmus and blepharospasm. Blepharospasm is spasm of the eyelids. So you can imagine it's hard to operate on your eye if your eyelids are squinched shut. And it's also hard to operate on your eye if your eyeballs, twitching back and forth. Succinylcholine does increase intraocular pressure, on average about 9 millimeters of mercury within about 1 to 4 minutes after administration. However, it's very short acting, and that increase is very transient. Remember, in that previous slide, I said about how it was sustained elevations of intraocular pressure that was associated with those complications. And so most people feel that succinylcholine effects on intraocular pressure is not associated with actual adverse events. But this is due to contraction of the extraocular muscles. It's also due to relaxation of the orbital smooth muscle and choroidal vascular dilation. Pretreatment with a non-depolarizing neuromuscular blocking agent such as cisatracurium may actually attenuate the increase in intraocular pressure, but it may not. Other factors that increase intraocular pressure is Trendelenburg positioning, or retching, or coughing. Anything that increases ICP would increase intraocular pressure. Anything that increases intravascular pressures or blood pressure would increase intraocular pressure. Also, having a tight face mask, laryngoscopy, endotracheal tube insertion, arterial hypertension, hypoxemia, hypoventilation, or hypercarbia all increase intraocular pressure. There seems to be minimal effects with just supraglottic airway insertion, particularly if it's an easy supraglottic airway insertion. If you want to lower intraocular pressure, you do the same things that you do to lower intracerebral pressure. You hyperventilate the patient and you lower their temperature. If you have an open globe, either an injury because you have a needle, a nail through the globe, or a patient who has had a corneal transplant that has not completely healed, any increase in intraocular pressure may cause extrusion of the contents of the eye, the aqueous humor, out of the eye, and if that happens, the patient will have permanent loss of vision. It can also cause just loss of vitreous or hemorrhage, which may impact the vision. Let's do a question. A 6-month-old female presents with strabismus for repair. Which of the following are you most likely to see on the ECG intraoperatively? A, premature ventricular contractions, B, supraventricular tachycardia, C, atrial fibrillation, D, bradycardia, and E, ventricular tachycardia. Which of these are most common in a child having strabismus surgery? It's going to be bradycardia. So bradycardia is part of the oculocardiac reflex, and when one stimulates the ocular part, the cardiac part is usually slowing. Bradycardia and asystole, it is usually not tachycardias or arrhythmias. Those can occur. So the preoperative assessment is important for these procedures, even though the surgeries themselves are very minimal often, because they eye surgery can be done in a variety of patients, from the very extreme premature infants to the very elderly. And as I mentioned in my previous lecture about the concerns about apnea in premature babies, that's why that would be important. And again, the very elderly, because of the increased risk of complications, both with age as well as the increased risk of complications with comorbid conditions. There's also altered pharmacokinetics and pharmacodynamics in these individuals because of their extremes of age. Then we talked about how there's an interaction with some of the eye medications and the anesthetic agents. Typically, though, routine laboratory testing is not necessary. It is necessary. It has not been shown to improve outcomes or decrease complications. However, physician assessment and indicated testing has been shown to lower risk. So the assessment is simply getting a complete history on the patient. What medical problems do they have? You want to know if the patient has heart failure or not. You want to know if they have an ICD, an LVAD. You want to know whether their conditions are stable, under control. You also want to know what allergies the patient has, what medications the patient takes. If the patient is taking antiplatelets and anticoagulants, it's controversial whether they should ever be stopped for patients undergoing eye surgery. Clearly, it's felt that for patients taking antiplatelets and anticoagulants who have vascular disease, that means they're taking these for secondary prophylaxis, undergoing cataract surgery, that the risk of thrombotic events are higher than the risk of bleeding events, even for those undergoing retro or peribulbar blocks. For retinal surgery, vitrectomies, that type of surgery where the bleeding risk is slightly higher, it becomes a little more controversial. In surveys of retinal surgeons, about 50% of them stop these drugs, about 50% of them do not stop these drugs. There has not been strong data to suggest that there's a significantly increased risk of bleeding when doing retinal surgery in patients who continue continue antiplatelets and anticoagulant medications. As I mentioned in my previous talk, in patients during that high-risk period, soon after stenting or cardiac surgery, cessation of antiplatelet anticoagulants are fraught with danger, are very concerning, and typically the risk of bleeding is not going to outweigh the risk of thrombosis. So in general, So I think the default should be to continue these agents in these patients undergoing eye surgeries, with a special exception for the times when you need to discontinue them. I think the only key thing that's really important is is the patient able to lie flat and still during this procedure. The things that inhibit patients lying flat and still are those who don't speak English, who won't be able to understand instructions, those who have kyphoscoliosis, those who have, back pain, lumbar disc disease, those who have COPD, those who have sleep apnea, those who are morbidly obese, those who are developmentally delayed or mentally incapable of following commands and holding still. And then those patients may need more specific preoperative preparation. There's various ophthalmologic medications that these patients use. Many of them are familiar to some of the drugs that you will be using, such as phenylephrine. Now, generally, one does not absorb enough phenylephrine across your eye to increase your blood pressure. Timolol is a beta blocker. It's rare, but it's possible for one to develop bradycardia and or heart block from ophthalmic timolol. But it can add to other beta blockers as well. Epinephrine, again, is generally not absorbed enough to cause tachycardia or significant vasoconstriction. Acetylcholine not at the anticholinesterases, again, not absorbed in high enough doses that they're going to interfere with your neuromuscular blockers, a reversal of that. Cyclopentolate is the drug that's used, it's cycloplegic, that's used to dilate your eyes. So the important reason to know whether that's being used is so you know the patient doesn't have a blown pupil, or if you're trying to check pupillary reflexes, the patient won't have that if they've been given that drug. But these drugs are absorbed systemically, and in some individuals, they can cause side effects and they can interfere with other drugs. The most important drug you probably should know about is a drug called ecothiopate. It's phospholine iodine. It's a meiosis-inducing anticholinesterase. It can be absorbed in significant enough doses that it can interfere with the metabolism of succinylcholine. And may cause prolonged paralysis. So I don't know how else to have you to do this, so just remember ecothiopate interferes with the metabolism of succinylcholine and may cause prolonged paralysis. So that has definitely been asked on the boards. So what anesthetic options do you have? Well, you can always do a general anesthetic, or you can do some kind of a block. The two most common blocks are retrobulbar or intraconal blocks, or peribulbar or extraconal blocks. I would say anesthesiologists tend to do more of the peribulbar, where ophthalmologists tend to do more of the retrobulbar blocks. Those are both types of subtenon blocks, essentially. And then there's topical analgesia, which is just topical eye drops that does not involve any needles or injections of local anesthetics. Again, it's felt that anticoagulants and antiplatelets are not contraindicated for any of the above techniques, even the blocks. We're going to spend a little time on the peribulbar and retrobulbar blocks. I'm going to show you a picture, but essentially there's 4 extraocular rectus muscles, and they form a cone extending from the origin at the apex of the orbit to the globe anteriorly. So if you imagine at the back of the eye is where they're all grouped together, and then they splay outward, going to the top or superior part of the eye to pull your eye and allow you to look upward. They're going to the bottom part of the globe to pull your eye downward and let you look at the floor. They're going to the right side or the lateral border of the right eye to allow you to look over to the right. That would be the nasal border of the left eye. Or if you wanted to look to the left, then you're using the extraocular muscle that's located on the lateral border of your left eye or the nasal border of your right eye to direct your vision laterally or to the left. So they form, there's a cone that's not dissimilar to the brachial plexus, where if one deposits medication in that inside area of those extraocular muscles, it will diffuse into the eye itself and numb up the eye. And it will diffuse into the nerve of the muscles, and numb up those muscles. So now the patient won't be able to move and the eye will be still and numb. So a retro means behind. Bulbar means is the globe. So it's drug that's injected behind the eye. It requires insertion of the needle deeper and angled from an inferior temporal to end up behind the eye. A peribulbar is just what it says. It's alongside the muscles. It's a more shallow depth. The needle's inserted more straight in, and it both of them. One uses local anesthetic. It takes a little bit longer for the diffusion from the peribulbar block to work. That's why these are typically done in the preoperative holding area by the anesthesiologist, where a retrobulbar block tends to work much faster, and these are typically done in the operating room and often by the ophthalmologist right before inducing anesthesia, though anesthesiologists and ophthalmologists can interchangeably do either one of these blocks. So here's a picture, I think, that shows you clearly the insertion of the needle is at the same point, whether you're doing retro or bulbar or peribulbar blocks. It just depends on how far in you put the needle and how you angle it. You can imagine if you're trying to just go alongside the eye versus behind the eye. So again, figure 3 is a cartoon figure showing you the insertion point. And cartoon 4, again, shows you laterally the needle coming inside the ocular muscles. On the far right bottom is the cartoon figure of the difference between the peribulbar and the retrobulbar. So you can see the trajectory of the needle, the angle of the needle, and the placement of the needle. Retrobulbar angled behind the globe, peribulbar straight in alongside, either top and bottom or left and right is also done, or temporal nasal. So the complications of both these blocks are retrobulbar, peribulbar hemorrhages, inducing the oculocardiac reflex, globe puncture, an intraocular injection where you don't intend to be, you're inside the globe itself, an optic nerve injury because you hit the optic nerve with the needle, or there's local anesthetic toxicity from being in close proximity to the optic nerve. A patient can have seizures because you gave a systemic injection of the local, or because you unlikely would be gave enough local that it got absorbed systemically. Any of these can result in blindness. There can also be spread of the local anesthetic directly to the brainstem because you're really, really close to the brainstem there. Or you can actually put your needle into the brainstem, which result in loss of consciousness, respiratory depression, the contralateral extraocular muscle paralysis. So you're injecting on the right eye, but the left eye is not being affected. So we mentioned about retinal surgery and how it's a little bit different than the cataract surgery. These are typically done for detachments. It's more common in patients who have diabetes and myopia because myopic patients have long eyes. Their retinas detach. There's different options surgical wise. They may do a vitrectomy. They may do what's called a scleral buckle. They may use laser. They may use cryotherapy, and they may inject an intravitreal gas. The reason some of these are important is depending on the anesthetic that's being done, how significant, how extensive the surgery is. These can be prolonged. There's a little more extensive eye manipulation than simply for cataract surgery. Often they are done with either general anesthesia or regional anesthesia with block. You can't use topical anesthesia for retinal surgery. The use of the insoluble gases are important. They usually use sulfur hexafluoride. It stays in the globe for up to 30 days. So if a patient has had eye surgery in the last 30 days, it would be important to be aware that if they had retinal surgery, that they could have gas there. The reason it's important is because nitrous oxide is contraindicated with the use of this gas, either during the time they're using it and injecting it, or for up to 30 days afterwards if the patient comes back for subsequent surgery. Because nitrous oxide diffuses into the eye, it would expand the gas, it would increase the pressure, it would increase intraocular pressure, and it could theoretically lead to vision loss. Another question, a 72-year-old working in his garage impaled a nail in his eye. Which of the following will increase risk of his losing his sight? A, placing him in Trendelenburg after he becomes vasovagal with insertion of his IV. B, the patient starts hyperventilating during placement of his IV. C, the use of midazolam after inserting his IV. D, use of general anesthesia rather than a retrobulbar block. Or E, using sevoflurane. Which of these will increase his risk of losing his sight, vision, losing vision? And it's placing him in Trendelenburg. So I mentioned how placing him in Trendelenburg will increase intraocular pressure. Increase intraocular pressure puts him at the risk of extravasating the contents of his eye through that opening where the nail is. Hyperventilating actually will lower his intraocular pressure. That'll be a good thing. Midazolam will lower his anxiety, which may lower his blood pressure, which is actually a good thing. And there doesn't seem to be any change in or any evidence of any difference in outcomes if with either the use of general or retrobulbar blocks. Sevoflurane would typically be a cardiac depressant, which would lower blood pressure, which would lower intraocular pressure secondarily. Strabismus surgery is surgery that's not in the globe itself, but it's surgery on the ocular muscles. It's usually to correct a lazy eye or disconjugate vision. It's much more common to do these in children, and it's much more common to do them in premature babies because premature babies have an increased risk of strabismus to begin with. It is considered to be on a spectrum of neuromuscular disorders. And it may be associated with other myopathies. In fact, it is associated often with other myopathies. So some patients just have strabismus, but many patients have strabismus plus other myopathic disorders. And it seems to be there's a very high risk or incidence of ocular cardiac reflex in patients undergoing strabismus surgery. And the ocular cardiac reflex is more common in children, and strabismus procedures are more common in children. There's also an increased incidence or risk of malignant hyperthermia in patients who have strabismus. People do use, though, succinylcholine in cases of strabismus repair, but it's considered to be a relative contraindication and safer to likely avoid using it, because most of these procedures with strabismus repair, or almost all of them, should be a planned surgery. So there shouldn't be any emergency surgery like an otherwise surgery. The patient may have a full stomach. Obviously, you could have a patient who had significant risks for aspiration that were higher than their risk of having MH, that you would elect to use succinylcholine and do a rapid sequence induction. But that would be pretty unusual in a situation with a young child who would be at higher risk for having MH. Or undetected MH than an older individual who may have had other surgeries already. There is a higher risk of master muscle spasm with the use of succinylcholine and during strabismus repair. And it used to be felt that if the patient did have master muscle spasm, that you needed to abort that procedure because that could be an indication the patient would be at risk for MH. Or sometimes it just simply is confusing in that the patient now is rigid, you can't open their mouth, and so there was concern that this may be the first indications of MH. But master muscle spasm is not associated in without fever. Fevers, hypercarbia, and all the other kind of symptoms and side effects of, symptoms or signs of MH do not occur with master muscle spasm. So now most of the time, if it's just master muscle spasm, it's felt safe to proceed with the surgery. There is an increased risk of nausea and vomiting in patients who have strabismus surgery. In fact, it's one of the highest risk of nausea and vomiting and is absolutely the most common reason for admission after this surgery. So it's really important that one sort of pull out all their guns they can to treat it. Dexamethasone, ondansetron, a scope patch. Be aware, by the way, that patients who have glaucoma have a contraindication to scope patches because that can increase the pressures of acute angle or closed angle glaucoma. And you want to avoid nitrous oxide just because nitrous oxide increases nausea and vomiting, so why add to it? So let's talk about the ocular cardiac reflex. I've alluded to that, and most of you probably know what it is, but an ocular cardiac reflex is a sudden decrease in heart rate when there's some kind of a stimulus around the eye. It can occur from external pressure on the globe, manipulation of the globe, traction or manipulation of the extraocular muscles. It's more common in young patients, and overall there's about a 15 to 80% incidence. The trigeminal nerve is the afferent limb. Don't ask me why they would do this, but they do. They torture you on the boards. They are known to ask what the afferent and efferent limbs are. So it's the ophthalmic branch of the trigeminal is the afferent. The efferent is the vagal. It's a little easier to remember the vagal because the vagal is bradycardia, and that's what it causes. And vagal goes to the heart, right? But the ophthalmic branch of the trigeminal, you just need to, know where those cranial nerves are. So the most common arrhythmias you see are junctional rhythm, bradycardia, asystole, AV block, but you can see ventricular escape beats and rarely other sort of tachyarrhythmias, but usually it's a slowing of the heart rate. Generally, as soon as you remove the stimulus, it goes away. And it does extinguish itself. So if there's a stimulus and the patient gets bradycardia, then if you stop and it goes away and then you do the stimulus again, likely is it won't even occur the second time. But if it does occur the second time, it's usually shorter lived, it's less severe. So most people often recommend not treating because just removing the stimulus takes it away. But if the bradycardia or say systole persists, or if it's really severe and you're concerned, atropine and glycopyrrolate are used for treatment. What's a little bit more controversial is whether you should prophylactically use atropine or glycopyrrolate to prevent the ocular cardiac reflex. And it's a little more effective in children to use. It's actually pretty ineffective as a prophylactic medication to use in adults. The other reason not to use in adults is because you don't want the adult patients typically to get tachycardic because they may have ischemia and you don't want to trigger that with tachycardia. So, of course, you wouldn't want to use it prophylactically in somebody who may not even get the oculocardiac reflex. Likewise, older individuals are less likely to get it to begin with, so less likely the need to use it prophylactically. The other way to abolish the oculocardiac reflex is with regional anesthesia. It's very, very effective because it blocks the input. It blocks the ophthalmic trigeminal nerve from sending signals in to the brainstem, so the signals can't come back. The vagal nerve will not be stimulated. So even if you didn't start out with a block, if you have a patient who seems to have recurrent oculocardiac reflex that not extinguishing or severe, then blocking that patient will be effective. So is the 3-year-old undergoing strabismus repair? Which of the following is true about the oculocardiac reflex? So hopefully you were listening and hopefully I was clear. A, pretreatment with glycopyrrolate or atropine may be effective in preventing it. B, pressure on the globe results in a sympathetic surge causing tachycardia. C, the afferent limb is the ophthalmic division of the facial nerve. D, the reflex does not occur when local anesthesia is used. So the correct answer is that. Again, pretreatment may prevent it. So pressure on the globe will cause the parasympathetic and bradycardia. Again, the trick with C is the afferent limb is the ophthalmic division, but not of the facial nerve, because the facial nerve does not have an ophthalmic division. It's the ophthalmic division of the trigeminal nerve. And the reason D is not correct is because the reflex does not occur if a block is used, local anesthetic agents with a block, but does occur when topical anesthesia, if just topical anesthesia is used. So sometimes you will encounter these patients who have traumatic injuries to the eye, and the reason that those are important is because the patient may not be in a fasting state. You may not have time to sort of optimize their medical conditions. It's considered generally an emergency surgery. So you can consider delaying repair until the stomach is empty, but generally when one has an injury, that's gastric emptying sort of slows down or ceases. So the clock starts from the time of the injury, not necessarily from the time of the last food. So for example, if the patient, ate an hour before they had the injury, even if they showed up to your operating room 3 hours later, the patient hasn't been fasting technically for 4 hours. The patient was fasting only for an hour because it was only an hour that elapsed between the time of the food intake and the injury. And again, because these are relatively emergency surgeries, often to save the patient's sight, there's an urgency, a time-sensitive matter to it. But it doesn't stop you from giving the patients prokinetic drugs and drugs to lower the acidity. The question is whether you want to truly do a rapid sequence induction or not. And a lot of that will depend on the patient's airway, of course, and how easy it is to manage their airway, as well as other comorbid conditions, such as a patient with heart failure, ischemia, or something. As we mentioned, succinylcholine-induced fasciculations do increase intraocular pressure, but typically it's transient and it's not significantly elevated. So some people consider a modified rapid sequence induction using rocuronium rather than succinylcholine. And of course, regional anesthesia may be an option as well. So we mentioned about factors that increase intraocular pressure, and there's not just pharmacologic. It's important to remember that, just having the face mask on very tightly, particularly up against the eye, can be a problem. The active laryngoscopy and placing an endotracheal tube with this increased noxious stimulus and increased blood pressure significantly increases intraocular pressure, so you want to have a good depth of anesthesia before doing so. Obviously, if you have a patient who you've avoided muscle relaxants on or not given a small amount of drug and the patient coughs, or they're challenging and difficult to get a tube in, or they go into laryngospasm, that is going to increase your extraocular pressure significantly more and for significantly longer compared to simply using succinylcholine. Again, an awake intubation may seem like the answer, but be careful because it can be very, very stimulating. So if you are going to use it because the patient truly has a difficult airway or a risk for aspiration, you want to make sure you do very good topicalization and use some anti-anxiolytic medications to make sure that there's not a severe rise in intraocular pressure. So you have a 72-year-old female who uses eye drops and is scheduled for an emergency appendectomy. Which drug may impact your choice of muscle relaxant? A, ecothiopate, interfering with succinylcholine metabolism. B, timolol, interfering with rocuronium onset. C, timolol, interfering with succinylcholine metabolism. D, ecothiopate, interfering with succinylcholine onset. E-cyclopentolate interfering with succinylcholine metabolism. So vote. Hopefully all of those you recognize as ophthalmologic medications. But which one is the most important one? And correct. And related to muscle relaxant. And yes, it's the ecothiopate interfering with succinylcholine metabolism. So the onset should be the same. It's just that it may result in succinylcholine not being metabolized, and so one would have a prolonged muscle relaxation. And because some of these eye procedures and this, like an emergency appendectomy, may be a very, very short operation, it may be significant. So cataract surgery, though, in general is very low risk surgery. The mortality is thought to be about 1 in 10,000. The mortality may not be able to be any lower than that because we typically do cataract surgery on elderly patients with significant comorbid conditions. These patients die for other reasons than just having cataract surgery. In fact, there was at least a couple of studies that suggested that patients who are having cataract surgery had a lower mortality that was predicted based on insurance projected mortality rates on the day and the day after they had their cataract surgery than they did for everyday life. So maybe if you're feeling particularly ill and think you may have a terminal illness, run out and have cataract surgery. The morbidity is also exceedingly low, thought to be about 0.04%. That's not 4%, but 0.04%. So that is, 4 in 10,000. The Cochrane review of a very large number of patients, several different, at least 3 big studies and some other smaller studies showed that the adverse medical event rate was about 3.3%. Only 0.28% hospitalization risk. Remember, I said for all ambulatory surgery, the risk of unanticipated hospitalization is about 3%. So this is, 1/10 of that. There were only 3 deaths. This is probably due to the fact that there's limited, maybe no stress response, no major organ disruption, no fluid shifts, no blood loss, minimal postoperative pain. In fact, there's no reason to interrupt any of the patient's medications. We talked about how you shouldn't be stopping anticoagulants, antiplatelets. One should probably not even be stopping oral hypoglycemic medications because these patients can literally eat soon as they are done with their cataract surgery. It may be avoidance of general anesthesia. Most of the time, the type of anesthesia does not significantly impact the risk of surgery because the overwhelming risk of surgery appears to be the surgery itself and the patient's comorbid condition, not the type of anesthesia we choose. Now, it's the conduct of that anesthesia may make a difference, but not the actual type of anesthesia. But there is at least one study in the literature showing that patients who underwent general anesthesia for cataract surgery had a higher incidence of intraoperative ischemic changes. There were no higher incidence of overt myocardial infarctions or death, but did have higher incidence of perioperative ischemia. And we do know that in general, perioperative ischemia is associated with a higher risk of long-term morbidity and mortality. So it's possible here that cataract surgery is so low risk that clearly a general anesthetic now may be a better a predictor of increased risk compared to blocks or topical anesthesia, unlike pretty much any other surgery situation.